Good afternoon and welcome to Medical Aid in Dying. Are you prepared to support the patient? Presented jointly by the Alliance for Home Health Quality and Innovation and the Visiting Nurse Associations of America. This session is being recorded. This continuing nursing education activity has been approved for one contact hour by the Maryland Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive your certificate of completion, you will need to attend this program in its entirety and complete the evaluation available in the conference app. Certificates of completion are available at the registration desk. Our faculty has disclosed no financial conflict of interest. A copy of the full disclosure sheet is available on the table outside the room. I'd now like to introduce you to today's presenters. Caroline Boaz is with Sharp Chula Vista Medical Center as a registered nurse and clinical nurse specialist and is growing their palliative medicine program. She's also nursing faculty at California State University. With over 20 years of experience in hospice and palliative care, Caroline has held positions of Associate Director for the California State University Institute for Palliative Care at Cal State San Marcos and Executive Director of Inpatient Services with San Diego Hospice and the Institute for Palliative Medicine. Stephanie Elkins has had a dynamic 20-year career in the nonprofit sector, successfully managing community-based programs, cultivating and developing strategic partnerships, and actively engaging volunteer leaders, most specifically in healthcare environments. In 2015, Stephanie came on board as California Medical Outreach and Organizing Manager for Compassionate Choices, where she was central in political campaign efforts to engage and collaborate with physicians and healthcare professionals, as well as medical associations for their endorsement of medical aid in dying as an end-of-life option. In addition to those efforts, Stephanie has had the privilege of working with religious leaders and faith-based organizations that became a vital voice and champions of the California End-of-Life Option Act. As the bill is passed, Stephanie's focus as part of the California Access Campaign is providing technical assistance for education and healthcare professionals and systems in ensuring medical aid in dying is a standard medical practice of end-of-life care. Prior to Compassionate Choices, Stephanie was Program and Outreach Director for Lisa's Care Connection. Her work focused on educating and empowering family caregivers for those with memory loss and/or chronic illness. This experience ignited Stephanie's passion to advocate for families and healthcare professionals to have important conversations regarding end-of-life options. Stephanie holds a master's in management specializing in human services and an MA in Jewish communal services or service from Brandeis University. She also has a BA in social relations from UC Riverside. Kathleen Hessler is a National Director of Compliance and Risk for Simeone Healthcare Consultants, LLC. Ms. Hessler and her team of compliance professionals provide ethics, compliance, and risk management services to home health and hospice companies. She's a current board member for the Texas and New Mexico Hospice Organization and a frequent speaker at state and national healthcare and legal conferences. Prior to joining Simeone, Ms. Hessler practiced healthcare law for 17 years, representing long-term and post-acute companies. In addition to her degrees in law and nursing, she holds certificates in healthcare compliance, HIPAA privacy compliance, and healthcare ethics. From 2010 to 2012, Ms. Hessler served as Director of Risk Management for Christus St. Vincent Regional Medical Center in Santa Fe, New Mexico, and was a member of the Hospital Ethics Committee. Without further ado.
Good afternoon. Thank you, Nate. So now that 15 minutes has been taken up, we'll proceed. No, we were planning to each do about 15 minutes and then leave some time for questions. So I'm going to go ahead. And this is a cartoon, courtesy of Stephanie. Sometimes, even if I stand in the middle of the room, no one acknowledges me. And I think that speaks volumes to many of the issues, ethical issues we're dealing with in healthcare today, and some of these controversial issues. I think some of you were probably in the medical marijuana session. I was not this time, but I was mentioning earlier to Stephanie and Carolyn that I think it's interesting in my years of practicing law, I've never experienced what we have today as so much conflict between state and federal law that we have today, more so than ever before, with many of the issues, especially the end-of-life issues and the medical marijuana and recreational marijuana issues. Can everyone hear me? Is this okay? Okay. So with that, these are the learning objectives for this session. I'm going to talk about bioethical principles applicable to ethical framework in an aid in dying analysis. So I'm going to go through a framework, and then Stephanie's going to talk about clinical competencies on medical aid in dying. She's going to go over the Oregon Death with Dignity experience, some of the statistics they've kept, and what meaningful data has come from that. And then Caroline will talk about medical aid in dying as a palliative practice, and we'll talk about 2 considerations in developing a system-wide policy and procedure for compliance with the law in the states where aid in dying is legal. So the path to aid in dying laws, I'm going to just give a little bit of a history here, statutory, regulatory, and common law. So the law, there's a yin and a yang, if you will, between the law and ethics. The law is basically, a violation of the law is, always dependent on facts as applied to the law. And for laws, there's accountability and punishment. Many states have assisted suicide laws versus the aid in dying laws. The states that have aid in dying or death with dignity distinguish between those of assisted suicide laws. Ethics, on the other hand, basically is dependent on someone's values. It's a system principle of right or wrong conduct, and it depends on your social or moral values of individuals, communities, families, corporations. Many organizations will have missions and values in their organization. So it's a set of rules or conduct governing a profession or business. And ethical judgments are based on the values, as I said, of individual, society, or company. And the values differ in different cultures, different organizations. So with the aid in dying, in the states where it's legal, the organizations you work in will more than likely develop policies based on the mission or the values of the organization as a whole. So, this is what we're looking at. There's always going to be conflict. For instance, in our country, laws themselves are often based on people's ethical values. An example would be, in our country, we value democracy. Other countries don't, but that's a value we have, so our laws are built around the democracy. And there are other types of values, social, religious, economic. I always talk about a cultural value. I am from New Mexico. I live in Albuquerque, and we have a rail runner train that goes from Albuquerque north to Santa Fe, and it goes through Native American land. And there is a conductor on that train that will walk through and ask people to refrain from taking pictures when we pass through a certain area of land because they value the land as sacred. So again, there's so many differences in what people value. Economically, some people might live paycheck to paycheck. Other people, might be more frugal. That's a value that we have. And corporations, as I said, company cultures have ethics and a culture of ethics. Some companies promote doing the right thing more than other companies do. And it's the same thing with bioethical principles. And in our country, we value, as a society, patient self-determination, autonomy, respect, responsibility, right to consent, right to refuse treatment, and now we have come to aid in dying. So what is ethical may be illegal. What is legal may be unethical. Those things are actually easy discussions, but the more complicated issues are when something is legal, or the less complicated are when something's legal and ethical or illegal and unethical. It's when you have something where someone's values or morals, tell them it's wrong or unethical, but the law says it's okay. So medical marijuana, aid in dying. What are some of the other examples that you would, in our society, that we read about every day in the paper, we hear about on the news, where there are laws that say it's okay, but ethically, depending on a person's morals or values, it's wrong? Anyone else have? Abortion? Pedophilia? That's probably wrong in most people's eyes, I would think. So it would be things that some people feel, that some people believe in are okay and ethical, and other people don't. So gun control, medical marijuana, gay rights, marriage, end of life. These are controversial issues where the law says it's okay in many places, but some people, regardless of what the law says, they think it's wrong. So, that's in our healthcare society that we have 3 bioethical principles, or 4 bioethical principles that I think are prevalent in bioethics, and that is the respect for autonomy, for the right of someone to make their own healthcare decisions, the right to refuse treatment. In bioethics, we talk about non-malfeasance, do no harm. We're going to treat a patient. We may have to balance risk and benefits. But there may be side effects to certain treatments, but we're bound by the principle of do no harm. Beneficence is do good. How do we treat the patient with minimal side effects, but to do good for that patient? And of course, distribution of justice has been a bioethical principle for many years, but I think it's really in recent years that we're seeing, the distribution of resources. How do we distribute resources? Even in the compliance area, the government coming back and taking monies back and monitoring more closely how care is delivered based on quality. So we're looking at distribution of justice for many reasons, for cost containment. But who gets this, and what is healthcare a right? That's another controversy in our country. But this is what I wanted to do, is just very briefly show you or illustrate, how did we get to where we are today with the progression of end-of-life, death with dignity laws. We had the history of informed consent. 1914, there was a case of alleged battery by a woman who had surgery, and she claimed the physician took out more than she had agreed to, hysterectomy. The judge came back and said yes, basically ruled in favor of the plaintiff. So, right away, in our country, we're over 100 years of the patient has a right to informed consent and make decisions. And then in World War II, we had experiments. There were experiments that came to light, not just in Germany with the Nazi treatment, but even in America, there were unethical studies. And I won't go into all of that, but abuses in human experimentation. And then we come up with the end-of-life issues, the Karen Ann Quinlan case, 1975, landmark case. The parents had a fight to have her removed have the ventilator removed. Then she ended up living 10 more years. Nancy Cruzan had a feeding tube. Her parents fought to have that removed. These are very historic landmark cases. We don't have time to go into them. But between 1976 and 1988, there were alleged 54 reported cases where the courts had to make decisions based on life-sustaining treatment. So what the court said is, this isn't what we should be doing. Congress needs to make these determinations. The people need to decide. So Congress passed the Self-Determination Act, which then allowed and mandated that the states each pass their own advance directive acts. And so now all 50 states have advance directives that allow patients to make their own decisions at the end of life. So you see this progression. And even in that, the Self-Determination Act went into effect 1991. Then we had, even with that, we had the Terry Schiavo case and all of the cases that went along with that, or the legal procedure. So many people still don't have advance directives, but that's a progression to where we are today. And informed consent, implied consent, people who are designated as agents have the right to stand in someone else's shoes to make judgments, substituted judgment on behalf of that person if the person is incapacitated. And if you have an agent and you haven't discussed what you would have wanted, the person's supposed to act in your best interests. But there is, this is running short on time here, I am, but there is a book. This is an interesting book, Clinical Ethics. It's an ethical approach to ethical decision making, a practical approach. And these are the 4 areas Dr. Johnson talks about when you're trying to make an ethical determination or trying to facilitate discussion to resolve an ethical dilemma. Talk about the medical issues, the patient preferences or wishes, if you know them, if the patient is alive, if the patient is incapacitated, what does the surrogate say, quality of life issues, and then outside issues. So the future is now. Again, our country continues to progress in its thinking about the patient's right to refuse treatment, to accept treatment, to demand certain treatments. And now people all across the country are looking to end of life issues, and many people want the option to make that decision when they die if they have a terminal illness. So with that, I'm going to turn this over to Stephanie.
Do you want me to leave this? Just this one? Oh,
Yeah,
she did.
you're here.
Hi, everybody. It's good to be here with all of you. So everybody has their story. I don't know if some of you are familiar. There's many. I think you saw it before in the picture, the last slide that you saw Brittany Menard, the young 29-year-old woman, a few years ago, 2.5 years ago, she came into all of our consciousness by her sharing her story from California. A young woman knew she was dying from a brain tumor, and since the law wasn't in California at the time, she moved up to Oregon, and she really changed the conversation by sharing her story about she was fortunate to have the resources and family support to move up to Oregon, but she realized not everybody does. And so she made it an effort in her remaining days with her family support to say, I want to share my story. My legacy is to make sure everybody has all the end-of-life options that's right for them. And so that was Brittany's story she shared with us around internationally, really changed the scope of all end-of-life options, including medical aid in dying, which is what I'm going to be talking a little bit more about. Dr. Gawande's book came out a couple years ago, Being Mortal, which is another great story that he shares, many of case stories, personal and professional, that we all walk around with, that kind of shape how we feel about end-of-life conversations. And his book is a great example of sharing stories, or what I really like and what I got out of his books is really the core to all this is really what's individuals' goals of care, what's important to them, and that's their own personal stories and conversations. Jennifer Glass was another individual, kind of like Brittany, who wanted to share her story, making a difference when 2.5 years ago, the option of California having the End-of-Life Option Act. And one thing about Jennifer, and I never realized before, but her bag says Fearless on it, and I can see it clearly here, but one of the other things she would say, I'm a fearless woman, I just want to fear less, especially at end of life when she had cancer, and the law didn't go into effect after she died, and what she was fighting for passed, but she didn't get the death experience that she wanted because it wasn't law yet, but she just wanted to fear less by having this option. So these wonderful, resilient individuals, that stories about wanting this option for themselves has affected many other people. So what are we talking about medical aid in dying? This is kind of our national model. It's a compassionate and palliative medical practice in which a terminally ill, mentally capable adult with a prognosis of less than 6 months to live has the option to request from their doctor a prescription for medication which they can choose to self-ingest to end unbearable suffering and die peacefully. So I want to just these kind of highlight some of the main perspectives, and this is really, I think, kind of core to go away with all of you is, what are we talking about? Terminally ill, mentally capable adult. So when people bring up some stories about younger individuals, it's not what we're talking about here. Less than 6 months to live in self-ingest, and we'll go through that a little bit more. As we were showing, this is where aid in dying is authorized right now. Those kind of requirements that I just reviewed with you, that's kind of statute. This is where, as you can see, just in the last couple of years, Colorado just went into, the law just passed there by ballot measure. Unbelievably, over 64% of Coloradans supported the law. I mean, it was a very high percentage there of support of individuals wanting this option, and in DC as well. This is just to give you a sense by color of different states. The blue states are where there's different volunteers, active individuals, but yellow is where other legislation, either by ballot legislation or by lawsuits, where there's tons of activity going on, and saying that this is something really that's changing, evolving across all states. So once again, here's kind of what we're just kind of another way of looking at the criteria, core safeguards and clinical criteria. 18 years or older, terminally ill, 6 months, capable of making medical decisions. That's really what I kind of really firsthand want you to walk away with this. What's true about this, and one of the reasons why that's important for me and a lot of medical directors and individuals I talk to, is when people ask about wanting aid in dying and want to talk about the End-of-Life Option Act, part of the conversations, what's built in all these laws, is having to have a conversation on all end-of-life options. So it's built into the law, and so it's really an opportunity for all healthcare professionals, when somebody asks about this, not to go into fear mode, but look at it as an opportunity for these bigger conversations of what kind of care someone really wants at end of life. If it be hospice and palliative care or voluntary stopping eating and drinking, it's really about an opportunity to discuss all end-of-life options and being present to where that patient might be. Once again, the other safeguard is a person must be able to self-administer the medication. This is a lot different than euthanasia. Some people might respond if they don't know the language, going, oh, you're talking about the euthanasia law. It's different because this is self-administered. What else? This is a very specific law with a lot of diligent requirements. 2 doctors need to agree on the eligibility, right? Let's go over the eligibility. Somebody tell me what one of the eligibility requirements are. Adult. Terminally ill. Prognosis of 6 months or less. State resident. Have capacity. Okay, so you need 2 doctors to agree on all these different layers. They're called an attending or consulting physician. It is all voluntary. for the doctors to participate or not, right? Once again, it's conscientious objectors for doctors wanting to participate. Going back to that ethical question, this can be a very big paradigm shift for a lot of clinical professionals when they're reviewing that. That's why the ethical framework is so important, to check in with yourself in terms of what your own personal and professional beliefs and ethics are. So the two doctors need to require the eligibility. There's a witness form, so you need two individuals also to confirm that you have there's informed consent and have capacity. There's also a waiting period between two of these requests. It's 15 days, so it's not like you're gonna go in one day and say, kind of like the last conversation about medical marijuana. You're not gonna go into a doctor and say, hey, this is something I'm interested in, give me, let's sign the records. It's a minimum of 15 days in between, and there's report forms that I have outside. It's part that you can kind of see all the questions both doctors have to go through in having a conversation with the individual with their request. If there is a concern about their person's mental health diagnosis, or if they have a disorder, then they can refer to a psychologist or a psychiatrist for a mental health evaluation. Wills, contracts, insurance, and annuity policies are not affected by a person choosing aid in dying. So once again, that's different than, medical aid in dying is not considered suicide or assisted suicide, when we know sometimes the insurance is affected by that. This is something that's also clear, and this is also written in the laws too, that it's not assisted suicide. But really, when I talk to healthcare professionals or individuals that work with individuals that might be suicidal, first that are interested in the aid in dying medication, it's a different conversation, because most of the individuals that I've talked to or have experienced who are interested in medical aid in dying have a terminal illness. They don't want to die, but they know they're dying. And that some have been prolonged with treatments and are some of the strongest individuals that I know. And this is not a private conversation, but it's a public one that you have to get your team more involved. And Caroline's going to be talking a little bit more about that. One of the other things I just actually wanted to talk to you about this, when we go to advanced healthcare directives, this is not a law. This aid in dying is not something you can write in your advanced healthcare directive that you want your agent to do on your behalf. Let me rewind. You can put whatever you want in your advanced healthcare directive, but this is not something an agent can do on your behalf. It's something that at this moment in time, you're doing on behalf of yourself. Okay, so I just want to make that clear. So it's a little different. The larger conversations should still be had. This talking about this additional end of life option goes hand in hand with advanced healthcare directive and the PULSE. Okay, this is an additional thing to be discussed, but it's for you that you have informed consent on it. Coverage. Once again, this is a state, when we talk about state and federal changes, this is a state law, so Medicare and VA does not cover the cost for it. End-of-life conversations can still be had, but in terms of in the records and record keeping, they need to be a resource or referral and refer out. Medi-Cal in California and other states has put money for medication and conversations towards that. Let's look at an overview of the Oregon experience right now. Once again, only over 1,700 prescriptions were written. 64% took the medication. It's only over 1,200 individuals that actually have taken the self-administered. The idea, and there's publications about that, the palliative effect, right? Just like kind of on a hospice sometimes, the palliative effect of knowing that you can have these conversations and somebody is open to being with you and saying, I will support you through this process if you decide to do it or not, has a huge palliative effect. And we're seeing more research and just talking to individuals that have gone through their process that are getting the medication. That's what we hear a lot of. Some of the other statistics, most were over the age of 65 and had a diagnosis of cancer. 89% were enrolled in hospice. Once again, those end-of-life conversations, we know from other research that people want to die at home, right? That's kind of where they want to be. We're knowing they're getting that interdisciplinary level of support. And not one instance of abuse in 19 years. this is a closely watched law, in terms of what's really going on, even here in California. So people, want to do what's legal and right by their patients and the health, with their own professional ethics of it all. Once again, another graph of the individuals that have utilized the law. As you can see, cancer is the main one, but ALS has been more prevalent in terms of individuals wanting to take advantage of aid in dying, but it's really about when they have that conversation and their level of capacity. These are some of the reasons that are given back. Once again, every year in the states that have this law, that the Department of Public Health puts out an annual report of that the doctors have to turn in the annual report of what some of the statistics of the reasons why that they decided to do it. So this information has come back every annually. In California, we'll be getting that by July for the first year because the law went into effect June of this last year. A 92% loss of autonomy, going back to the ethics and the democracy of the country we live in, that's really held at high regard. Once again, Oregon, 19 years of practice in Oregon, having a prescription aid has provided comfort. People use the law to minimize pain and suffering, not to save money. Once again, this is, pain management, palliative care, we know provides many benefits and so on, and that is part of the conversation as well. One of the other things, especially in the California law, the elderly and people with disabilities and people of color have not been coerced or abused. Once again, these are conversations, intimate conversations that are had with individuals, doctors, and families. So there's been no sign of coercion. Back to that over 19 years of practice. What? We're going to wait to the end for questions. There are a lot of organizations out there, healthcare associations, that have endorsed medical aid in dying or have provided a neutral stance, which is once again allowing their own membership to decide how they want to support, what their own views are of support. So this just kind of gives you an example of some of those healthcare organizations that have endorsed, went neutral, and there's a lot of shift going on across the country of allowing opportunities for these larger end-of-life conversations, including medical aid in dying. Once again, was mentioned earlier that we're here as Compassion and Choices is to provide technical assistance. So we do have some information outside in front about the clinical criteria of the laws or some general information on all end-of-life options. And we also have some wonderful volunteers that are in the San Diego community that are also here because our main thing is access, which is providing public and provider education in the community. And so we have individual volunteers that are also healthcare professionals that are providing education and support in terms of developing policies and support. So I'm going to end it right there, and I'm going to give it to Caroline.
One of the things I forgot to ask, how many of you are with hospices? How many with home health? And how many from California? Okay. Because one of the things I just want to mention, I'm from New Mexico, and we just had a bill in our legislature for End-of-Life Options Act, which was very broadly written and did not have many of these safeguards. So you want to make sure, Stephanie's talking about these safeguards, and I think Washington, Oregon, and California, I believe, have these safeguards, but if you're from other states, make sure that you understand your state law or the bills going through the legislature on what they contain. Our bill did not pass for that very reason. Many of the people in the House Judiciary Committee said it needs to go back for more safeguards.
Yeah.
But
What states are you in? I know you're new. Washington? New York? Okay. Great. California. Okay, you can still be from somewhere. All right, thank you. Oh, it's not in here. Yeah, I don't think so. Okay, video's not in.
Hello. So, this whole movement really follows the same footsteps as hospice. I don't know if any of you were around when hospice was sort of forming, and it was controversial back in the day. And now it's so mainstream. I mean, it's an accepted part of what we do at end of life. And You know, I believe that medical aid in dying will get there. Maybe not in my lifetime, but, you know, we're following those footsteps. It's already becoming more and more mainstream, as you can see by how much legislation is on the books already, and we're headed in that direction. So it has great momentum now, and, you know, part of what we do as volunteers and speakers and things like that is to try to start to normalize that this is part of the conversation. I like this cartoon. It says, you've got 6 months, but with aggressive treatment, we can make that seem much longer. And working in palliative care as I do, I work in an acute care center, I see people whose dying really is terrible, honestly. And I'm sure that it probably seems quite long to them at times. Even families, they'll say, oh my goodness, what's taking them so long to die? You know, they never thought those words would come out of their mouth, but, you know, we're so good at keeping people alive even when their bodies are nearly dead. It's really remarkable. And you know, I really see that our roles are really to deliver patient-centered care. So what does that mean, to deliver patient-centered care? That really means to me that we really are addressing what that patient wants, that we're having those conversations, that they're the choosers of what care they get. You know, so much of the time, I remember my parents' generation, you just listen to what the doctor says and you just do it and you don't question. You know, they didn't even have these conversations about, you know, sit down with your patient and ask them, what is it you want? What are your goals? You know, what's important to you? Now, our doctors, you know, they all take this Hippocratic oath, right? And when that oath was written, it says, give no deadly drug to any, though it be asked of them, nor will they counsel such. But I think in Hippocrates' time, you know, they didn't have the same illnesses that we have now. They never heard of the things that we've gone through. People got sick and they died, you know, and now we keep people alive much, much longer. And that wasn't a consideration at that time. And really, physicians recognize that, and others of us in the health profession, you know, that really we're in a different time now. And that the oath written as it was probably doesn't apply, and certainly ethically it doesn't. You know, ethically we have all these other considerations now because we're keeping people alive much, much longer. So in practice, I'll just share a story. So I work for Sharp Healthcare System, and we were a little behind the ball. So this became law last June, and we didn't get our policy together until this year. And I was already getting requests before we actually had a policy. And I got one request from an elderly woman. It was really important to her that she wanted medical aid in dying, and we couldn't offer it to her. So I called Stephanie and said, hey, who down here in San Diego has got their act together in hospice that could help this patient of mine? And she connected me with a hospice down here, and we called them, and they came, and they were able to take her into the service and help her get the ball rolling. Unfortunately, she died before she had an opportunity to make her 2 requests, so it came too late, which unfortunately that sometimes happens. People get close to the very end and they're like, hey, I want to do this, and then they've run out of time. I most recently had a patient in the emergency department who came in and said, I want medical aid in dying, and I had seen him at a previous hospitalization. Every time he got chemo, he came in with horrible pain. And so I sat down with him, and we sat down and talked about it. I brought him the information sheet and gave him some of the overview, and then I just, you know, said neutrally, but what is it you're choosing? Why do you choose this? What's going on with you? And he said, I have so much pain, I'm afraid that I can't bear the pain. And I said, you know what, we're good at pain and palliative care. We're really good at that, and we're good at that in hospice too, and I think we can probably take care of this kind of pain that you're having. So I really encourage you to let us manage pain first before you jump to this level. So even though we have it available, it doesn't mean it's the right thing to do necessarily, and I want people to be very reflective on that and in their presentation to patients. You know, yes, this is an option, but is it the right option for you? And as it turned out, we got his pain managed by the next day. He said, you know, I don't think I want to do this. And I said, okay, great. You know, you have the information, you change your mind, it's fine, but, you know, really let's handle the thing that's really concerning you. So, you know, I didn't freak out. Nobody freaked out. We gave him the information, and it wasn't the right thing at that time. So this is, as Stephanie said, one treatment of many treatments. And, you know, some of the things we can do is offer everything that we can And that's sort of the smorgasbord, right? We go to the hospital, they say, okay, we're going to do all of these things for you, particularly if you have cancer, you know, first line of treatment, second line of treatment, third line of treatment. You're welcome to do all of those things. The second, though, is you can refuse care. And I often have to talk to my patients about that, especially those that have been on dialysis for a long time, have a lot of comorbid conditions. You know, you can stop dialysis. And they said, I can? Gee, nobody talked to me about that. I'm like, sure you can. And this is what it will look like if you do that. You know, this is, your time will be short, and this is what it will, your ending will look like. It's really not a bad deal. I said, but yes, you have choices. And then there's palliative care. And palliative sedation, are you all familiar with palliative sedation? Have you heard of that? Palliative sedation is where you actually medicate a person to the point of coma. So that you only use this in extreme cases where somebody's pain or symptoms are unreasonable, that they just really can't bear them. I've used it with patients with ALS who were going to be suffocating at the end of their life and really couldn't bear that. So we would give them a medication so that they weren't aware of their lack of ability to breathe until they actually died, and that is legal. There's voluntary stopping eating and drinking. This is legal in all states. Anybody can choose to stop eating and drinking. And so I educate my patients on this as well, and I've had patients, many over the years, that have volunteered to do this. Within 3 to 6 days, they're typically in a coma, and then within 6 to 14 days, usually they'll go ahead and die. And typically it's hard, you know, and you need some support to get through that, but that's certainly another option. And then there's medical aid in dying. So, you know, I want to sort of normalize that this is just another option. And as Stephanie said, a really small percent of the population are going to take advantage of this. What is it? Maybe 1% in Oregon of people have taken advantage of that. So it's you know, the other options are definitely much more prevalent. So what do you consider if you're going to be developing a policy or procedure for your agency? To do this, you know, I want you to be really conscientious about it and pull together a multidisciplinary team. So don't let just the nurses or just the doctors or just the administrators, you know, get the social workers and the chaplains and get a group of people together that can really bring perspective on what this means to pull this together. Will you be supportive, and at what level? So let's talk about abandoning our patients. You know, this is something I'm really concerned about when I've heard hospices say, yeah, we're going to allow it to happen, but we're not going to let our nurses be there when they mix the medications. Or, okay, well, they can be there when they mix the medications, but they can't be in the room with them when they ingest it. Is that fair? I mean, you hospice nurses know you've developed a really deep relationship with your patients and families. Is it right for you to not be there when they need you the most? So these are all considerations if you're going to be developing a policy. And what kind of education is going to be provided to your staff? You know, are they going to know how to handle these questions when the patients say, I want to take advantage of this new law? Do they know how to respond to that? And what about conscientious objectors? You're going to have those too. And you know, people should be allowed to decide to, you know, whether it's within their comfort zone to actually participate in this. Oops, I think I was off a slide. Sorry about that. Okay, liability and professional protections. So at least here, there is no obligation to participate. There's no liability for medical providers that act in good faith under the End of Life Option Act. And people can choose to object. I know at Sharp that a lot of our physicians are hired by our Sharp-Rees-Steely group. When it became law and the policy was being developed, they just surveyed them all, who wants to opt in, who wants to opt out. They have a whole list. They don't share that publicly, but we know who the prescribers will be and who absolutely won't be a prescriber. So that if one of the physicians has a patient making the request, they can refer them to one of their colleagues if there happen to be somebody who objects to the law on some moral basis. So again, you have to really look at, you know, how will you handle that as an agency if you have, you know, nurses that choose not to participate. So I have to say, I know I have a palliative care physician in the audience here, that the stand with the palliative care community by and large has been no to medical aid in dying. They say, you know what, if if we do good palliative care, we should be able to manage our patients well. They shouldn't need this. We can get their pain managed. We can handle all these things. But, I've been doing this work a long time, and sometimes we just can't fix the things that ail people the most. And it's not just about pain, it's about other things too. And I truly believe that medical aid in dying, as an option, is palliative in itself. And I know Stephanie spoke to that. Just knowing that that option is available to me personally makes me feel comforted that, if I come close to the end of my life and I know I'm going to have to endure certain things, having my partner change my diaper, unacceptable. I just don't want to go there, and it's just my personal thing. If you're okay with me, I would change his diaper. That would be all right. But I don't want him changing mine. So, it's so personal. But some of the great benefits are providing that peace of mind for our terminally ill patients. Those that receive the medications, they say they have a higher quality ratings on symptom management, just knowing that they have the option, and that, in fact, it relieves worries about future discomfort, pain, and loss of control. So just psychologically, they do better. And let's remember my patient, too, the one with all the pain. It's just, he thought, okay, I have this option. He asked about it, and I said, I think we can control this pain, and in fact, we did. And he was all good with it. He didn't need it then. So just really having those conversations. So it improves end-of-life care, just having the option available. Most of our research does come out of Oregon because they've been doing this for such a long time. Again, it's just one option of many. It requires that the physician really talk to their patients about all of their options. And a lot of our physicians don't do that. So it's really great that now they have this obligation that they have to sit down with the patient and say, look, we have all these options. You can make some choices. They have these deeper discussions. Research in Oregon did say that really the greatest benefit was that it's relieving this anxiety about future, fear about future discomfort and pain. Many of the prescriptions never get filled. Only 64% used it actually in Oregon. So a lot of times those prescriptions just sit there and never get filled, and there's nothing wrong with that. It does promote hospice use, appropriate hospice use. So most patients that take advantage of this are actually on hospice and pursue it. So it's, that's another advantage of it, because we tend to get people in too late, and people who have the states that have this law, people are more encouraged to participate because they're having those conversations earlier. So put them together, we get improved care. We're talking more, we're having careful evaluations. And the other thing is that we're talking more in our families. I have so many families, they're like, well, did you ever talk about, what was going to happen at the end of life? And by and large, no, people don't talk about it. No, we never talked about it. If people are considering medical aid in dying, they're talking to their families. So it really opens up the communication about what their goals are, what's acceptable, how they want it to be at the end of life. So it really does a good job of making sure that families are in really open communication. They're making a plan. They can say their goodbyes. We can make sure they're at home and not in the intensive care units. So it just really provides a much better situation. And that elephant in the room that Kathleen talked about is suddenly not an elephant anymore. We can talk about what's going on. And just briefly, I just want to talk really briefly about language. I think language is really important. The people who make the news and want to sell newspapers, they love to use words like suicide. So I just want to just make a mention about when you're putting your program together, language will matter a lot, the way you present it. It is legally and medically inaccurate to call it suicide, and some of the reasons are up here. The word suicide doesn't really describe the experience of a patient and people around them when they're getting medical aid in dying. There's open communication, there's inclusion, there's leave-taking, there's completion, there's openness, and you won't use any of those words around suicide. I've lost friends to suicide, I've had friends who've lost their kids to suicide, and it's none of those things. It has a completely different feel. And it's different from euthanasia, as Stephanie said, because it is self-administered. So euthanasia indicates that somebody else has administered it. So, all right, well, I'm going to kind of close with that because I want to have a moment to hear your thoughts and any questions you might have. And then we have a reference sheet. So, anybody have questions? Yes?
I have two questions. You made a statement earlier about 1% of
1% of the total population is all that have actually accessed the law, that wanted to participate in end of life.
37 out of 10,000 deaths.
Yeah. Yeah. So even though it's available to everybody, very few people take advantage of it. And typically, less than 1%, yeah, and it's typically white, college-educated, higher income levels. You know, it's interesting with the population that tend to choose.
My second question was on one of Stephanie's slides, and you talked about, I think I can speak loudly enough, but thank you. You talked about, you made a statement about people of color not being coerced. And I need to understand the connection between people of color and coercion.
You know, some of the arguments for individuals that are in opposition to the law, that's been a argument that people against law have brought up, like the slippery, like that there's coercion going to be going on with this law. And so we just acknowledge that has not been the case.
So is there a greater impact on people with color? Is that what?
It's not. It hasn't been, but as we bring it up because that's what the opposition has brought up in media and so on, is use of why there should not be an aid in dying law. That people will go and promote end of life option, promote aid in dying instead of other options for vulnerable population.
Yeah, it's more
For vulnerable populations.
vulnerable
Okay.
population, I think.
Because I could see with elderly and the disabled, I could not make the connection with people of color.
Okay.
So I was challenging that.
Okay.
In terms of access to the law, you mentioned that some are not able to get through the 15 days. So in changing these laws going forward in other states, what do you think of then making that waiting period 13, well, pardon me, not maybe 13 days, but maybe 7 days or 10 days rather than 15 days?
You know, the way that the Oregon law has been right now for almost 20 years now, and there's been no coercion or abuse. We don't see that change happening as soon as we're rolling it out across the country. So it's not something that time frame, because these are long conversations, so that's not an area that's being looked at right now in terms of that minimum time frame. If somebody's already at that stage, we're promoting conversation sooner than really focusing on that change of that 15-day period.
And just remember that that's state law, and New Mexico had no waiting period in their law. So again, depending on, many states who are introducing this legislation are using the Oregon law as their model.
Yes, I understand. Everything's been modeled on the Oregon experience from 20 years ago, which 15 days was taken out of thin air and seems to me to be a bump to utilization of this law. And so why not consider 12 days or 10 days or 7 days?
It'll be up to the people, the legislature.
Sure, and I think going forward, this is something to consider.
Did you want to know you had some interplay in the New Mexico law?
Yeah, I'm one of the people that worked on that bill that was not restrictive enough or not didn't have, quote, safeguards. And I want to speak to that just a little bit. I feel that the Oregon model has become the national model, and it was designed to be extraordinarily conservative because they were trying to pass it as a legislative, as a state ballot measure. And I think we're all boxed in by it now. Some critical issues in New Mexico are we were the first state that was going to advocate for nurse practitioners, advanced practice, RNs, and PAs being allowed to both prescribe and have conversations with patients around aid in dying. That was one of the first things that got kicked to the sidelines. And that was really concerning to me because we're in a very rural state, and there are many places where there are a very limited number of practitioners. And so by limiting it to physicians only, by going back to 2 physicians, in a rural state, you're making access very poor. The waiting restriction is another thing where someone from a rural area may be driving down to Albuquerque twice, not once. So there are many concerns I have for exactly in line with what you're saying.
Right. Yeah, and I think that that'll, over time, just like the advanced directive laws, every state is unique in their geography and the availability of resources, so.
And
I
how the,
mean,
yeah. And how the law is
legislatures
written,
can
if it's by
change
ballot
that.
measure
Yeah.
or by
Yeah.
legislation.
So, but I think these are all good points. I mean, that was the model, and that's how, how laws get started, across the country, and then, the legislature might modify or amend. The new states, the states that are introducing legislation might decide not to do or use the Oregon model. Just, as was just pointed out.
Or we have our nurse practitioner or physician come to the home and help them with paperwork, because these are the sickest of the sick people, don't make them travel at all, let's just do it all at home.
So that's why I think it's really important to remember that depending on where you live and where you come from, these are not federal laws. So you want to make sure you understand your state law as it applies. The companies that actually go across state lines or cover multiple states, you'll have to figure out, from a corporate standpoint, do you want a company policy that covers all states, and of course, if you have a company policy in some states, aid and dying is illegal, then you have to make sure the states where it's legal that those agencies understand what your company policy is. So, those are things that you need to consider, because we are, this is a national association, so, not everybody is equal in what you're dealing with. And I think it's important to raise those issues in your company.
Has anyone here, besides this table, because I know you're, has anybody, especially in authorized states, which is where the laws are, have had opportunities or conversations come up to you about aid and dying? How's it been?
And maybe just a full disclosure, I work for a Catholic health system
Okay.
in the state of Washington. And I would have to respectfully challenge any kind of a thought about nurse abandonment. We did not abandon our patients. We could not be present when the prescription was being ingested, and we had a policy that was that we very carefully crafted and trained. But we were a Catholic health organization. I don't work there any longer, so I can't speak for them. But yeah, it was a very big deal.
Right. So was there a feeling there, just because sometimes it's, I think the corporate culture of different places, like a lot of health systems, did it still provided education and support that you could be present or have conversations? Was there kind of a feeling of no, if somebody brought it up, you couldn't talk about it?
Absolutely not.
Okay,
We supported the patient all the way through the end of life, and that's part of the support that you provide.
Yeah, okay. I mean, sometimes it's just
Yeah.
culture. Okay.
Yeah.
Good insight.
Yeah.
So we're at time, but we had one quick question that I wanted to get to before.
Do you have a lot of people that move to Oregon for aid and dying?
We don't, so in terms of track, first of all, once again, we want people to talk to their own doctors wherever they are about getting the best care they are in other states. So it's not
For
something
states
we're
that don't have the law in practice?
We don't track that, so we don't know how many people move to other places for aid and dying. So that's not something we kind of track. We haven't heard, the Brittany experience is not, I think what people are it's not like a destination thing. We don't see it happening a lot. It's just not a frequent thing for people moving.
I guess my thinking through that is that, how long does it take to establish residency and things like that in that time period?
All you need is a driver's license or a state ID that says you live here.
It's not a time-based
It
thing.
can be one day.
But in terms of a lot of places, one of the nuances about getting your kind of care, sometimes when because this is a new policy, sometimes people say, I'll do it for my own patients, but if you're somebody new coming in for this level of care, they're not automatically going to take you in for maybe aid and dying. So there's all these nuances. So it's the idea of really getting the best care. But in terms of the qualifications in California, it's not time-based. It's like having some sort of something in your name.
Does the law stipulate exactly what medications are used?
The law is quiet on the medications, but there is clinical criteria information about some of the medications that are used. It's usually certain different protocols or cocktails that are used, and usually fast-acting barbiturates are kind of used. It's kind of put into about 100 capsules in a liquid form that somebody has to drink in a quick period of time with an anti-nausea medication as well. We do have a pharmacist-to-pharmacist hotline that does kind of go over some of the various protocols and costs associated and process with that. So,
Thanks.
the laws apply on medications.
We will be at the reception tonight, right? Or if anyone has any other questions?
Yep, so we're at time, but I want to thank everybody for coming and the panelists for their